At our hospital, we have been using a second circuit with a double lumen tube in thoracic surgery for almost 6 years. We have found it a very effective means of monitoring double lumen tube positions, and we wish to identify minor double lumen tube position abnormalities to prevent complete loss of lung isolation, which can be injurious, potentially catastrophic. The other two advantages of using a separate circuit are the ability to apply different oxygen concentrations to the two lungs for protection for both lungs and to achieve better control of lung reinflation for testing and recruitment without the need to adjust ventilator settings. After perfect positioning the double lumen tube with the flexible bronchoscope, the double lumen tube can still move. It will only move in an outward direction unless deliberately pushed inward. Causes of outward movement include ventilation pressure, surgical manipulation of the lung, weight of the circuit, swelling of the face and tongue, light anesthesia, and importantly, too much air in the bronchial or distal cuff. What we wish to detect with our circuit is when, on outward movement, the bronchial or distal cuff begins to move into the larger carina. If only the correct amount of air has been placed into the cuff, a leak will develop around the cuff. While on one lung ventilation, air under pressure from the ventilated lung will go around the cuff and exit the path of least resistance out the lumen of the double lumen tube to atmosphere. It will not affect the lung on the side of surgery. In contrast to the common technique, when this leak around the bronchial cuff occurs, it will give an early warning that we should reposition the double lumen tube inward. The air will accumulate in the manual ventilation bag of our circuit, providing a visual cue to do so. In the past, we have used commercially available neonatal resuscitation circuits, as well as the Mallinckrodt CPAP device used in thoracic anesthesia. We are currently using our own house-manufactured circuit. It is assembled by our anesthesia assistant team. It is composed of parts that will be available in any hospital that is doing surgery and has an ICU. We start with a highly compliant manual ventilation bag with a hole cut in its tip. We use a ventilator filter to attach to the endotracheal tube connector on the double lumen tube. The oxygen supply is from the auxiliary oxygen flow meter on our anesthesia ventilator table. We connect our oxygen supply to the sampling port of the ventilator filter. We use high-flow corrugated tubing from the ICU to connect our manual ventilation bag. This allows us to place the manual ventilation bag on the ventilator table or wherever it is most easily visible during the case, next to the oxygen flow meter and the pressure manometer. We add a connector to allow us to apply a pressure manometer, and we also add a snap over the hole which we have cut in the ventilation bag so that we can completely close the circuit when desired. Here is the circuit with the bag placed on the anesthesia ventilator table. We see in this picture that we have a disposable pressure manometer. The blue tubing is going to the right lung, which is, in this scenario, the non-ventilated lung, and we see the same connector that we use, filter, we are ventilating in this case, or in this simulation, the left lung. We will now show how we determine the correct amount of air to be placed in the bronchial cuff, and also how we ensure that the double lumen tube is not so large that no air needs to be injected into the cuff. In this case, we are going to be operating on the right lung, and I have my bag attached. I attach my bag, there's no leak, the cuff is in the correct place. Now I'm going to show you how much air, I'm going to show myself creating a leak, and this is how we determine how much air to put into the distal cuff. I'm going to withdraw air slowly, make sure I'm ventilating here. I'm going to withdraw air, and there you see the bag begins to inflate. There it stops inflating. So it's a minimum amount of air in that distal cuff we need. So I'm going to withdraw all the air just so we can see how much air we need in the distal cuff in this patient. Okay, so there. In this man, this is a 39.2. Air is still going in. Okay, we've stopped the leak. There's no more leak, as you can see. Now I'm going to empty the bag again, so I just want to show us something here. We see that the bag moves with ventilation. It's filling up and then collapsing. Filling up. Air is not accumulating in the bag. That's because what we're observing is we're observing the effective ventilation pushing air in and out of the lung that we are not ventilating. Now what I'm going to do is I'm going to gradually pull back on the tube until I create a leak again. There, we see now we got air accumulation there. We stopped. So now we can see I just created a herniation in the cuff. So this is a very useful monitor when we're positioning the patient to the lateral decubitus. We start one lung ventilation from the time of initial placement of the double lumen tube in the supine position. We have the patient on one lung ventilation while transitioning. We are monitoring for position of the double lumen tube during positioning. We don't have to overflex the head. If I see that bag begin to inflate, it would be very simple for me to just push it inward. I'm very confident that after this movement, when I go back down with the flexible bronchoscope, that double lumen tube position would be very close to what it was when I started. There is no risk of having low oxygen saturations with movement or being on the one lung ventilation. The chest has not been opened yet. We have 100% oxygen in the corrugated tubing, and also if we need, we can manually ventilate that lung. With the snap over the hole in our manual ventilation bag, our circuit can be oversensitive. Small, very slow accumulations of air over 1 to 2 minutes may be seen. To avoid being distracted by these non-significant leaks, I prefer to remove the oxygen tubing from the auxiliary oxygen flow meter when I am not ventilating or testing the lung. Technically, before the chest is entered, we cannot be on one lung ventilation because of indirect ventilation. The positive pressure of the ventilated lung is transmitted to the non-ventilated lung. We won't always see the bag movement that I'm going to show. For example, in morbid obesity or severe lung disease, we may detect minimal or no bag movement, but it is significant. In the video clip, I'm going to show the indirect ventilation is with 100% oxygen. In the common technique on going to one lung ventilation before chest entry, the anesthesiologist will start one lung ventilation by opening the double lumen tube to atmosphere pressure. It can be seen that after 4 or even 10 minutes while the surgeon is entering the lung, that oxygen concentration can drop significantly. While watching this movement of the air in and out of the bag, indirect ventilation, bear in mind that the dead space with the double lumen tube is very small. In chronic obstructive lung disease, air trapping in alveoli below closing volumes can inhibit deflation. On the bar graph, what we see represented on the y-axis is volume, on the x-axis is time. The blue represents oxygen, the blue represents nitrogen, the yellow represents oxygen. Over time, the alveoli where air is trapped will deflate in volume until the oxygen remaining in the alveolus will equal that of mixed venous oxygen, or about 15 volumes percent. On the right side of the bar graph, we are representing alveoli trapped, but with 100% oxygen in them. Over time, as the mixed venous blood absorbs oxygen from the alveolus, the oxygen concentrations remain high. This is why the denitrogenated lung will collapse more effectively, and also why we will see fewer instances of low oxygen saturations that are significant immediately following opening of the chest and collapse of the lung. The most important monitor for pressure in our circuit is the skilled hands and eyes of the anesthesiologist. When testing for leaks and for recruitment of alveoli at the end of surgery and pressures greater than 20 centimeters of water are used, a dedicated pressure monitor is important. For pressures higher than about 20 centimeters of water, if we don't have a separate manometer system, we should probably just use the anesthesia ventilator as in the traditional technique by switching to manual mode. We have here an adapter that allows us to connect to a pressure manometer. One option is this disposable manometer. It's accurate to about 30 centimeters of water pressure. The other option, especially for higher airway pressure requests, are to use the traditional pressure manometer. When ventilating with the circuit or testing the lung for leaks, I prefer to remove the snap from the hole in the bag. This gives me greater control. If I suddenly find that pressures are too high, there's instantaneous release of pressure within the circuit. I simply squeeze the hole in the bag off between my thumb and fingers and just open the bag. Pressures will drop to zero instantly. This is a quicker release of pressure that can be obtained by opening an adjustable pressure limiting valve or by turning off oxygen flow. When I'm ventilating manually, I turn the oxygen flow up quite high, and using the bag, pinching the hole off in the bag, I manually ventilate. This is more what I would do if I'm flushing the circuit with oxygen prior to, for example, chest entry. You can see here that those wrinkles in the bag are not disappearing completely. The wrinkles in the bag will disappear completely at 20 centimeters of water. I'm flushing the circuit. Here we see this works like a Bain circuit. Oxygen is being flushed out of that hose and out of the manual ventilation bag. When it comes time to test the lung for leaks or to recruit chronic lactatic alveoli, I prefer to go much slower. I have all the time in the world since I'm not switching ventilation to the dependent lung. I turn the oxygen flow way down and squeeze the bag, going very slowly. This technique, I believe, is safer than the traditional technique as I have better control. I can release excessive pressure instantly just by opening the hole in the bag to atmosphere. The pressure will drop instantaneously back. Thank you for watching. Please provide any questions and comments you have, and we will provide a response. We hope you have enjoyed this video.